So the first speaker is Dr. Bill Travis. And then there is no need for introduction on him because he's a giant in the field of lung cancer pathology. He has been involved in the multiple very, very important projects, including WHO, editing WHO book in several editions. And then also he wrote the very important subtype classification of lung adenocarcinomas. Right, and he has been involved in the staging committee of the IASLC, and that is very important task as well. So he is today he's going to talk us about the updates on subtyping and classification of lung cancer. So 2 minutes before 8 o'clock, but Bill, please.
Well, thank you, Mari. It's a privilege to be able to work with you on this course over now many years. And I have to say, this is one of my favorite educational activities, working with Mari and Lida, and of course, Natasha. It's a real privilege to work with these amazing colleagues. And I'm so happy to see so many from all around the world are able to participate. I have no real disclosures except being a non-paid consultant for this clinical trial. So I'm going to talk about updates in classification and diagnosis in lung cancer, and it's such a broad topic, and Mari and Lida have designed such a wonderful program. It covers the whole WHO classification, and so it was a challenge to figure out what to talk about. So I'm going to focus mostly on adenocarcinoma, less so on squamous carcinoma. And you'll hear about all of the variants and unusual types of tumors throughout from the other lecturers. So this is the 2021 WHO book, which was led by Dr. Ian Cree, which you can see here. Here are all the various editors, and these are the various topics. So as we have gone from the 1967 WHO, which is largely based on H&E, to the 2021 WHO, it has become increasingly complex. And I know that sometimes this is used as a criticism, but in fact, what it has done is made our role in patient care increasingly relevant for personalized medicine. So whereas we started with H&E, now we have cytology, immunohistochemistry, genetics, histochemical stains, particularly mucin, and radiologic correlations. You're going to hear about all of these exciting details and advances during this course. And I always like to show this slide just to show you the impact of advances in lung cancer. So this is from the American Cancer Society. And you can see in this red curve the rapid drop in mortality for lung cancer, both in males on the top and females here on the bottom. And while a lot of this may be related to things like smoking cessation and CT screening, a lot of it is related to advances in therapy, which much of which is molecular targeted therapy or immunotherapy, where our role is huge in contributing to identifying molecular markers as we process the tissues for molecular testing, interpret the results, include those informations in our reports. So we are right in the middle of all of these exciting advances in and I always point this out to trainees so they realize a lot of what seems like busy work, in fact, is incredibly valuable for patient care. Overall mortality trends are largely driven by lung cancer, for which decline steepens similarly in men and women in recent years for the reasons that I just mentioned. And the annual decrease in lung cancer mortality accelerated from 2% per year during the years 2005 to 2013 to 4% during 2013 to 2021. And this is absolutely astonishing. The lung cancer death rate dropped by 59% from the peak in 1990 to 2021 in men, and from 36% from the peak in 2002 in women. So what about some of the emerging topics in lung adenocarcinoma? We'll talk about the cribiform pattern, micropapillary grading spread through air spaces. So these are the major histologic subtypes. Lipidic here on the left, where the alveolar wall architecture is preserved, atypical cells, pneumocytes proliferating along the surface. Here is the acinar pattern. Here is the solid pattern. You can even see some intracytoplasmic mucin. This is a papillary pattern with true fibrovascular cores. This is a micropapillary pattern lacking fibrovascular cores. This is the cribiform pattern where you see this sieve-like arrangement of the glands. This is known to be an aggressive variant of acinar pattern, and there are multiple papers that demonstrate this. This pattern, along with the signet ring pattern, is known to be associated with ALK and ROS1 fusions. So this is the classical or floret micropapillary pattern you see here on the left, where you have these micropapillary clusters lacking fibrovascular cores. And several years ago, we described this filigree pattern where you see stacks of tumor cells lacking fibrovascular cores protruding from the edges of these air spaces toward the lumen. And we require at least 3 piled up nuclei because we want to make sure we exclude tangential cut of tumor glands. In this study by Katsura Emoto in collaboration with our group here, we were able to demonstrate that the classical in purple and filigree in yellow had the worst cumulative incidence of recurrence compared to the other subtypes. And we could not identify any difference between these two. So that validated that filigree should be included in the recognition of micropapillary pattern. Now, that being said, when we report micropapillary, we don't try to estimate percentages of filigree versus classical. We just want to make sure we include whatever filigree that we see in the percentage of micropapillary. So you can have a stromal pattern of micropapillary where you see this sieve-like spread of tumor cells, micropapillary clusters of tumor cells in spaces within connective tissue. This is probably one of the more important things to recognize, is that even when you have acinar papillary or even lipidic tumor surrounding air spaces that are filled with a micropapillary pattern, the default pattern should be called micropapillary. And in our consultation material and material coming from the outside, we see this overlooked many times. So be sure you take a good look at the air spaces before you just assume you have a acinar or papillary pattern or papillary pattern. You can also get rings as a manifestation of micropapillary pattern. And you can have a single cell pattern, as you see here. And my experience is that if you see psammoma-like calcification, it's frequently there's micropapillary around. So if you haven't seen any micropapillary and you see some microcalcifications, go back and look. And I, not uncommonly, go back and look and find that I had overlooked some micropapillary component. So in summary, for micropapillary patterns, we have the classical floret pattern, filigree. We've talked about the micropapillary clusters within air spaces, surrounded by otherwise lipidic acinar or papillary areas, the stromal pattern, single cell pattern, which sometimes has been called the DIP pattern, ring-like structures in psammoma bodies. So going the wrong direction there. Here we go. Okay, so I'm going to now talk about the lipidic patterns of adenocarcinoma in situ and minimally invasive adenocarcinoma. Both of these are tumors that we defined in the 2011 classification to have a 100% disease-free survival if completely resected. And because we were replacing the term bronchoalveolar carcinoma, which had meant many different things, this 3-centimeter cutoff was quite important. And there was not a whole lot of literature at the time, but what literature we had was either below 3 or even 2 centimeters. And all of that indicated that indeed that these criteria should predict 100% disease-free survival. And in fact, the subsequent literature seems to have validated that. Most of these are non-mucinous. Rarely you get mucinous tumors. So for AIS, the tumor should be purely lipidic without an invasive component. For minimally invasive adenocarcinoma, the tumor should be lipidic predominant with 5 millimeters or less of invasion. And in order to diagnose these, the entire lesion needs to be sampled. You can't diagnose these on a core biopsy, only on a completely sampled resection specimen. Here's an example by CT. These typically will look like a pure ground glass nodule. Then here in the center, you'll see this circumscribed but not encapsulated tumor that has pure lipidic growth, no invasion. Here on higher power, you can see the same. Here is another example of a case where we have a pure ground glass nodule, but you can get increased amounts of connective tissue. That is simply benign scarring. So there's no invasion in this. Everything is still pure lipidic. In contrast, this is minimally invasive adenocarcinoma. It's a ground glass predominant lesion by CT, has a solid component in the center. And here you see the lipidic component on the bottom and the acinar component on the top and over here on the right. This is a lipidic predominant adenocarcinoma by CT. It's almost entirely ground glass, but then as you scroll through the lesion, there's this solid area that measured 0.8 cm by CT. And here by histology at low power, you can see it's a lipidic predominant, but then there's this solid area, which on higher view clearly shows an invasive component. So Koichi Kadota, who worked with us for many years, did a variety of important studies, but this one looked at the lipidic tumors we had at the time, including lipidic predominant adenocarcinoma, minimally invasive adenocarcinoma, and adenocarcinoma in situ. And out of about 1,000 cases, the lipidic predominants were about 10%, minimally invasive 3%, AIS 0.2%. And as expected, AIS and MIA had 100% disease-free survival, lipidic predominant 91%, and the other patterns 80%. And so I asked him, why did the tumors recur, leading to a 91% disease-free survival? There were only 4 of those 100 tumors had recurrences, and 2 were distant, 2 were local, 2 had closed stapled margins, 2 had lymphatic and or vascular invasion, and 2 had micropapillary patterns. So the ones that recurred, 3 out of 4 had good reasons for there to be recurrences. So grading really had never been established for lung adenocarcinoma, and Mari Mino Knudsen, along with Andrea Moreira, led this project through the ISLC Pathology Committee and made a very important contribution, coming up with an ISLC grading system, but this is only for non-mucinous lung adenocarcinomas. So the well-differentiated tumors were lipidic predominant with no or less than 20% high-grade patterns, moderately differentiated acinar or papillary predominant with no or less than 20% high-grade patterns, poorly differentiated any tumor with 20% or more of high-grade patterns. The high-grade patterns are solid, micropapillary, in cribiform or fused glands or complex glands. And there's a whole lot of literature about this validating it. And here you can see the survival curves nicely demonstrate significant survival. I'm next going to talk about spread through air spaces. This is defined as tumor cell spread beyond the edge of the main tumor into the surrounding air spaces. We require at least one airspace but beyond the tumor edge, and at least two airspace clusters and exclusion of artifacts. So here is a adenocarcinoma at the bottom of the field with the edge outlined with this black mark, and it's hard to see a little bit on the H&E at low power, but as we get closer, you can see these clusters here. I've outlined them all in red for you to see how extensive the spread is of tumor beyond the edge. And we have a whole set of criteria to distinguish these from artifacts. Floaters are typically randomly situated at the edge of the tissue or out of the plane of section. Jagged edges of the tumor cell clusters suggest fragmentation. Normal epithelium is fairly simple to recognize. Linear strips of cells lifted off the alveolar walls also favor an artifact. Alveolar macrophages look quite different. And if you don't have a continuous spread from the edge of the tumor and you just have isolated clusters at a distance, that favors an artifact. So here you see just an isolated group of tumor cells sitting on the pleura. Here is another cluster that are isolated well away from the tumor without a continuous spread from the edge. Here is a tumor cluster with a very jagged edge suggesting artifact. Here you can see there are isolated nests of tumor cells quite distant from the edge of the tumor. There's no tumor cells in the intervening air spaces. Here is one sitting right up against the pleura, and it looks like it's squeezed. So we were able to, through the ISLC staging committee, to analyze data collected for the 9th edition. And this paper was published earlier this year. And the data were so convincing that we were able to recommend that STAS be added as a histologic descriptor in the 9th edition of the TNM. So it will be collected more rigorously starting for the 10th edition. This is just a summary of the multivariate analyses. And as you can see, everything in green shows a hazard ratio that is significant in multivariate analysis where all of these factors were included. And for every subgroup, non-small cell lung cancer, the total group, adeno alone, other histology, which is mostly squamous, lobectomy, and sublobar resection, STAS is an independent predictor of outcome. So in summary, STAS can be distinguished from artifacts. There's this article which we need to get published showing that with lung pathologists. It's prognostic in all major histologic subtype, particularly in limited resections. There's data suggesting this is not a grossing artifact. However, we did not use this for percentage of patterns or tumor size and staging, and it's now going to be a histologic descriptor. So I'm going to now talk about squamous cell carcinoma briefly. Squamous cell carcinoma classification has evolved considerably in WHO classifications from 2004, where we had papillary, clear cell, small cell, and basaloid, to 2021, where we have keratinizing, non-keratinizing basaloid and lymphoepithelial carcinoma. So here is florid keratinization, where you see nice squamous pearls. And if you look closely and if you have a nice high power magnification, you can see the intracellular bridges. One thing we've learned with the introduction of immunohistochemistry is that it's really required now if you have a non-keratinizing tumor to do immunohistochemistry. You need to see a positive P40 and like to see a negative TTF1. Same is true for basaloid squamous cell carcinoma. Sometimes you see some keratinization, but most of the time you do not. So you need here a positive P40 and negative TTF1. And if the P40 is negative, you need to also think about neuroendocrine tumors. So here you can see this nicely demonstrated, and I can't emphasize this enough. This is a major transformation in our clinical practice to be now having to do immunohistochemistry. Here I'm giving you a much better view of these intracellular bridges. And it's easy to fantasize about these and think you see them. And then when you do your immunohistochemistry, you're kind of disappointed that the tumor has P40 negativity and TTF positivity. Here is a endobronchial papillary squamous cell carcinoma. These are quite unusual. Here's an example of a case that I signed out probably 2005 or 2006 and called it a squamous cell carcinoma. And this is what I'm talking about. It almost looks like there are intracellular bridges. You can see the sharp demarcation between the tumor cells, abundant eosinophilic cytoplasm. And the oncologist called me and said, why is this case that you called squamous carcinoma got an EGFR mutation? And I said, oh my goodness. Went back and did a TTF1, and lo and behold, it was positive. There was even mucin in this case. So this was one of the early lessons, and we learned from molecular testing that, in fact, we really do need to do immunohistochemistry in these poorly differentiated tumors. So with the basaloid squamous carcinomas, they notoriously have what's called abrupt keratinization. Here is an example of that. And they can also have rosettes. So on an H&E, these could be easily mistaken for large cell neuroendocrine or even small cell carcinoma. But with a P40, it can demonstrate that it's diffusely positive, confirming, in fact, that this is a basaloid squame. Here's a case that both Dr. Reckman and I looked at on H&E and said, that's a beautiful small cell carcinoma. And it's got all the characteristic features which she'll describe elegantly to you in her lecture on neuroendocrine tumors. And no nucleoli, finely granulated nuclear chromatin, high mitotic rate, nuclear molding. And I just fell off my chair when the fellow brought this immunos, and it's diffusely P40 positive. So we used to diagnose small cell carcinoma on H&E, and what we've learned is now you have to do immunohistochemistry to confirm the diagnosis. This is lymphoepithelial-like carcinoma, where you see abundant lymphoid stroma. You see the syncytial-like appearance to the tumor cells. And here you have keratin positivity. And here you can see the EBER is positive. By the way, this is a tumor that often occurs in Asian female never smokers. So if you hear that clinical history, it doesn't necessarily, usually makes you think about an EGFR mutation. But in fact, this is another clinical scenario that can result in that clinical history. So always keep this tumor in mind when you have a squamous cell carcinoma, and it is a patient with an Asian descent. This is the diagnostic criteria from the WHO, non-keratinizing squamous cell with syncytial appearing tumor cells, vesicular nuclei, distinct nucleoli, and a lymphoplasmacytic infiltrate within the tumor islands. And of course, you need to exclude a metastasis from the nasopharyngeal region. And you like to see the EBER positivity. I'd like to show this study from Koichi Kudoda, another important one, where he took a set of cases that had been diagnosed as squamous cell carcinoma here at Memorial and applied a set of immunostains, including 2 TTF antibodies, the more specific DACO 8G7G3 and the more sensitive, less specific SPT24 antibody. And you'll hear more about these in the subsequent lecture on immunohistochemistry. So there were 52% turned out to be keratinizing tumors, and all of these had P40 expression. There was one that also had an adenocarcinoma component, so an adenosquamous. These are the non-keratinizing tumors, which are 40%, and these are the basaloid tumors, which are 8%. And as you can see, as we work through the evaluation, we had some cases that turn out to be large cell neuroendocrine carcinoma, and some that turn out to be large cell carcinoma. And what I would like to point out is that, of course, we're more confident when we have a DACO antibody, more specific antibody, the 8G7G3 antibody, showing adenocarcinoma. But in fact, some of those tumors that were negative for that antibody were positive for the SPT24. So we were able to find 4% of the tumors were changed to adenocarcinoma using the SPT24, but 7% with the DACO antibody. In the basaloid carcinomas, we had the ability to show emergence of large cell neuroendocrine and small cell carcinoma in 2 cases each. So in summary, 94% of the tumors remained as squamous cell, but 4.2% were reclassified as adeno. 1.3% is high-grade neuroendocrine carcinoma. About 1% is large cell carcinoma. So immunohistochemistry is extremely important in this differential once you get into the non-keratinizing tumors. So in summary, I've talked about adenocarcinoma, the histologic subtyping, grading, and STAS, adenocarcinomas with lipidic patterns, and squamous cell carcinoma with the histologic subtypes and immunohistochemistry. And thank you very much.